Welcome back. The PTAC meeting will resume. Jim and the PCDT laid the foundation for this public meeting and some of the questions we want to explore and a framework to consider that. I'm excited to welcome our first roundtable panel. At this time, I'll ask our panelists to go ahead and turn on video if they haven't done so already. In this session, we've invited 5 esteemed experts to discuss their perspectives on reducing barriers to participating in population-based total cost of care models. After each panelist offers a brief overview of their work and thoughts, I'll facilitate the discussion by asking each panelist questions on that topic to discuss amongst themselves and with the committee. The full biographies of our panelists can be found online, along with other materials for today's meeting. I will briefly introduce each of our guests and give them a few minutes each to introduce themselves. After those 5 introductions, we'll have plenty of time for questions and to engage in what we hope will be a robust discussion. First, we have Dr. Christopher Crow, Chief Executive Officer and co-founder of Catalyst Health Group. Chris, welcome.
Thank you. Well, it looks like you have my background here on the slide. So rather than read it, I'll just kind of give you a quick highlight. Maybe we can get to the next person quicker. But these are the things we do at Catalyst Health Group. I'm a family physician by training. Grew up in a really small town that had 3 family physicians that really oriented how I think about the world and how I think about how we can take care of our populations across the nation. And so I've kind of created an ecosystem of companies along the way over the last 25 years that include, the largest independent primary care group in probably the whole Southwest, maybe the second in the nation, that's still privately held by physicians, a services organization that supports that, and then a broader network of primary care physicians that are independent in nature. For the last 10 years is how we started across Amarillo area, North Texas and East Texas. And really what the purpose of what we do is how do we help communities thrive through bringing better primary care access and performance to those communities. We believe that the 3 pillars of any community to actually thrive are healthcare, education, and jobs. And any one of those 3 pillars being off will make it where it's very difficult for a community to thrive. So we try to do our part to really push past what I would call the fee-for-service that I'm very public in how I think that is the devil of primary care, to really do a more of a population or perspective payment, or what all the kids now call their subscriptions of primary care, because uniquely in healthcare, that's a longitudinal relationship that can now last years and decades, versus some of the other things in healthcare where I understand they're reactive point by point transactions that need that fee for service. So we built a constellation of things around that. We have done some things with a not-for-profit that we built in 2020 to get to underserved areas that don't have insurance. We've also done some things around pharmacy with Stellus that is now national, that's helping primary care physicians all over the country that are at risk for Medicare better perform as well. So I'll leave it at that and look forward to the conversation.
Thank you. Next, we have Mr. Chase Hammon, who's Chief Financial Officer at Dooley Health and Care. Chase, please go ahead.
Yeah, good morning, and thanks for having me. Currently, I serve as CFO at Dooley Healthcare, which is we've got about 1,000 physicians over 3 geographies, mostly in Chicagoland. Multi-specialty group. We've got ASCs, labs, primary care, and most specialties. Before this, I was at Springfield Clinic, which is a very similar group in Central Illinois, about 700 providers. And then I also spent time in a very large health system, Bon Secours Mercy Health, in the Richmond office, and before that, academic medicine. So I've served the healthcare ecosystem and patients, and what I would consider most of the large and more popular ways of serving patients: academics, large health system, nonprofit, independent, and private equity owned. And I'm excited about today's conversation. I think patient care should be led by providers. physicians and APPs. I think that's where the cost of care is the best. We show 20 to 30% lower cost of care than most systems, and they're the ones that are really trained to care for our patients. So when we think about how do we remove barriers to what I'd consider really good care, I think it starts with the economics associated with it, the burden in standing up and then growing those business lines. And it's really difficult to do without size and scale. And that's, I think, why a lot of smaller physician groups just simply don't do it. It's too burdensome and too uncertain for most groups to do. So I look forward to digging into this and spending some more time on it.
Thank you, Chase. Next, we have Ms. Jessica Walradt, who's Vice President of Finance, VBC Contracting and Performance at Northwestern Medicine. Jess, welcome.
Hi, thank you, and thanks for the opportunity to participate in today's panel. As you noted, I'm speaking on behalf of Northwestern Medicine, and that's a health system in Northeastern Illinois that employs over 3,500 physicians. We have 11 hospitals, one of which is an academic medical center located in downtown Chicago. We participate in a number of VBC contracts, commercial, Medicare Advantage, as well as the Medicare Shared Savings Program, and historically have participated in Medicare bundled payment programs like BPCI Advanced and the Oncology Care Model. And our participation in those programs is what's influencing my comments today. Next slide, please. So when assessing participation in an alternative payment model, there's a lot of things we consider, and this slide highlights some of the major questions that we contemplate and which aspects of program design influence our thinking. And I'll just cover a couple of them briefly right now. So since we include an academic medical center, education, discovery, innovation are core to our strategy. And we are a destination for patients with advanced complex conditions. So we look at very closely a model's risk adjustment methodology, the attribution methodology, whether or not there are certain carve-outs. And those factors also influence our thinking about whether we ultimately believe there's a clinically appropriate path to generate savings. And to illustrate that concept, I included this graph on the slide that shows data from our actual experience in the oncology care model. So each of the bar graphs represent average episode payments for a lung cancer episode. And the green reflects the portion of that is driven by inpatient hospital stays. And then that orange yellow is the range of our target prices across performance periods. And you can see here that if we eliminated every single inpatient stay, meaning all of that green for a lung cancer episode patient, we still would not have been able to come below our target price. So we did not see a clinically feasible path to savings in this program. And it's one of the reasons that we're not in the enhancing oncology model today. And then I think there's a lot of factors that everyone on this call thinks about, like data, administrative operational lift, if you can meet the implementation demands within the timeline given, things like that. And I'm happy to talk about that in more detail and our other learnings from our participation in these models later in the conversation today. Thank you.
Thank you. Next, we have Mr. Brock Slabach, who's Chief Operating Officer at the National Rural Health Association. Brock, please go ahead.
Well, thank you. And it's good to be with all of you this morning. I'm joining you from Leawood, Kansas, and I am the Chief Operations Officer of the National Rural Health Association. Prior to my experience having come aboard the NRHA in 2008 was being a rural hospital administrator from 1987 to 2007. About 20 years. And so my discussion, or my frame of reference for my discussion today, will be not only my current role in looking at value-based care initiatives and their impact on rural providers, but also my experience as a rural hospital administrator historically. I wanted to kind of give a baseline of some of the activities in rural facilities around the United States. And I particularly want to point your attention to the upper left graphic, which shows participation in quality payment models by rural facilities, in this case, critical access hospitals. You'll see here that Medicare ACO, 47% currently of rural critical access hospitals are participating in some form of an accountable care organization, 26% in a Medicaid-styled accountable care organization, 28% in commercial ACO, and then about 14% in a PCMH or patient-centered medical home. I wanted to point this out because I think that sometimes we think that rural providers are not that interested maybe in innovation, but I would say that it's quite the contrary. I think there's a lot of interest in transforming care at the bedside so that it can become more cost-effective with higher quality to the patients that we serve in our facilities. The other thing I'll point out on this graph is that critical access hospitals, of which there are 1,360 nationwide, about 54% are independent, meaning they are not affiliated with a larger system. So we have some real opportunity in terms of networking and bringing alliances together of facilities, perhaps in terms of aggregation, to be able to make these value-based care models more effective. Next slide, please. I wanted to provide some context because I think it's important when we're looking at total cost of care models that would be applied in a rural context. 43% of our hospitals in rural areas are currently operating with a negative margin. Right now, Medicare Advantage is accounting for 39% of all Medicare eligible care patients in rural communities. And in many states, 7, the penetration exceeds 50%. So if we're looking at a Medicare-only model, for example, more and more patients are being peeled out of the participation cohort that it would make effective utilization of these programs. 182 hospitals have closed or have ended their inpatient care, and we're counting about 432 hospitals in rural areas that are vulnerable to closure. And during the same time period between 2011 and 2022, we've seen a significant loss in obstetrical care in rural areas, 293 having dropped this service, which represents over 25% of America's rural obstetrical units. So this is another reason, and we look at oftentimes obstetrics as being a precursor to a hospital closure. Next slide. I wanted to offer some rural considerations in the total cost of care modeling as it applies to rural facilities. I think one of the big factors in rural communities in their hospitals and clinics is the bench strength of leadership to implement transformational programming. Often in rural facilities, you have an administrator, a CFO, and then you have a whole line of department directors. And this makes it very difficult to implement innovation. A lack of clarity around risk and reward analysis. I think Jessica did a tremendous job of giving us an example of how to look at a model that projects what the participation would be in terms of financial impact. Often in rural facilities, it's almost impossible to understand the impact. And so when you're talking to a board of trustees about putting your assets at risk to participate in a model, that's a very difficult conversation. We have found in little or no appetite for double-sided risk models. And this is another example of the lack of clarity around risk-reward analysis. I already mentioned the thin margins that our hospitals are operating under with no capital to invest in these kinds of value-based care programming. The other thing that's very present, and I wanted to point this out early, is that the historic churn of VBC or value-based care programming that is either changed or terminated. we have seen a constant stream of programs that have either come into place, rural providers participate, and then the program is ended, leaving them in a lurch with no place else to go. Lack of alignment across multiple payers on payment incentives and quality metrics. We find that because of this lack of bench strength, the alignment across payers is often different, and it has oftentimes confusing or at cross purposes sorts of impacts in terms of the program. And then I already mentioned the increasing diversion of patients from traditional Medicare to Medicare Advantage, which has decreased the population of patients that would participate in a Medicare-only program. With that, I will turn it back over to our host, and thank you very much.
Thank you, Brock, for those comments. Last, we have Mr. Michael Barbati, who's Vice President of Government Programs at Advocate Health. Welcome, Michael.
Thank you. Good morning. So my name is Mike Barbati. I'm the Vice President of Government Programs at Advocate Health. I also serve as the President of Advocate Physician Partners Accountable Care, Inc., which is a 200,000 person MS Medicare Shared Savings Program Enhanced Track ACO, as well as the President for our ACO Reach, which is the Accountable Care Organization of Advocate Aurora Health. So a little bit about Advocate Health. We have a pluralistic physician model that includes over 600 individual independently aligned practices, as well as our employed physicians that serve patients across both rural and urban geographic areas across Illinois, Wisconsin, North Carolina, Georgia, and with some service sites in Alabama and South Carolina. This is a snapshot of our population health platform. We've got 15 ACOs, clinically integrated networks, as well as physician networks across our footprint. We manage 2.4 million managed care lives. We've got 110 plus value-based care contracts. My responsibilities do include any value-based contract that comes out of CMS, CMMI, and Medicaid. And so we've generated almost $750 million in taxpayer savings across a variety of models dating back to 2015. And then we've paid about $1.4 billion out in savings to our participating physicians since 2018. We've got 73 participating hospitals across the footprint. We dabble in all of the variety of payers from Medicare, Medicaid, and commercial capitated risk. Quite a large footprint. And then each of these networks is typically physician governed with equal representation between employed and aligned physicians. And then, we have invested over the last 10 years significant amounts of dollars into our population health platform, infrastructure related to care management, utilization management, other services. And we've spent a lot of time testing and working on specialty and nested care models to embed within some of our total cost of care dollars. And to give you an idea of, we've got about $260 million in budgeted revenue across these value-based contracts. And then our largest payer in our VBCs is CMS. Go to the next slide. So just want to talk about some of the participation barriers. While we've been in population health and been managing risk since our beginnings in 2009, we still face a lot of the burdens that other health systems across the country face. And I think part of them are typically assessing new models or total cost of care across our disparate geographies. We don't have a continuous geography, and so certainly the different insurance regulations by state. Fee schedules look different across states, and so and we have different levels of readiness. And as we look at tight turnaround times for total cost of care models from CMS and CMMI, that can limit our ability to apply, but as well as our ability to participate. Typically, in most of our value-based contracts, we're taking on Part A risk, and that typically leads to higher financial exposure, meaning that we need a higher level of certainty on the value-based care contract terms and ensure that it's going to be more profitable than our fee-for-service in order to take that downside risk. But, we struggle with some of the data silos and interoperability issues, lack of standards from, differing standards from CMS, from payers, from our vendors, certainly create some data silos, and for an organization like ours, creates an area where we do need to invest significant resources in the technology and data infrastructure to be successful in these models. And then I think just one other area to touch on, fragmented sort of care plan designs, different benefit structures for MA versus, different waivers for some of our value-based contracts with CMS and CMMI, as well as sort of disjointed and unconnected care models in the specialty space. We firmly believe that nested care models and embedding specialty care within our total cost of care models is a foundation of our future from a population health standpoint. And we've seen in some of our markets difficulty in managing both specialty care models as well as total cost of care models in the same market where they're not connected, or physicians and participating organizations don't have the opportunity to participate in both. But looking forward to the discussion today, and excited to dig in.
Wonderful. Thank you for that, Michael. Great introductions. Now let's move on to some questions. In the interest of balancing across different perspectives and questions, we'll encourage panelists to keep the response to a few minutes each, but then I will have a order to speak in, and then we will pitch each question open to the committee for follow-up questions and give you a chance for further elucidation. So question one, the committee would like to hear your thoughts on what are the most important factors affecting different kinds of healthcare organizations' decisions about whether and how to participate in a population-based total cost of care model. We'll start first with Chase, and then Jess, and then Michael, and then other comments. So Chase.
Yeah, thanks, Kim. I think organizational structure is a really big deal. Like I said, I've worked in various organizational structures, primarily on the physician side, and physician-owned versus private equity-backed versus nonprofit health system and academics. They all have different views of the world, as it were. I think Brock said it well when thinking about rural healthcare, or at least healthcare outside of large metropolitan areas like Dallas and Chicago, where I've been. The ability for these organizations to stand up the infrastructure necessary is really small, and combine that with the uncertainty around the data, around profitability. Mike mentioned, right, is the profitability for their fee-for-service side going to go down right by participating in the VBC? It's almost always yes for these smaller organizations. So and then I think a lot of our physician groups have come together. The independent physician groups have come together. Small for group becomes a larger group, becomes a really large group. That's how Dooley was created. It's how Springfield Clinic was created. It's how many of these, I think, Dr. Crow's group was kind of created that way over time. And what that does is you've got these silos of practices, individual practices that kind of operate on a revenue minus expense model or worker review model that doesn't really jive with managing a population. And so when I say organizational structure, it's also ownership structure. It really helps guide whether the physicians doing the work, right, are kind of team-based players that can play in a population space. I think again, one of the other biggest challenges is certainty and timing of cash flow and payments, right? That's a really big deal for independent physician groups. So I'm going to do the work now but not get paid for 12 to 18 months, as compared to fee-for-service, where I get paid in 2 to 6 weeks, maybe a little bit longer for some payers. right? It's a real struggle for those independent groups to get over that hurdle of all right, maybe profitability is better, but I won't know that, for 3, 6, 12, 18 months. And it's a significant barrier. I'll stop talking, let someone else talk, but these burdens are pretty significant. And the hurdles to get over them are big.
Yeah, great point about cash flow. Next, let's hear from Jess.
Yeah, so there's a lot of things that influence our thinking about whether to participate in a total cost of care model, but I'll just give one example that's unique to Northwestern based on our structure, and that's the fact that we employ 2 large multi-specialty group practices. So our ACO is 20% primary care clinicians, 80% specialist, and that means that right now the factor or a factor that is really going to answer the whether it's long-term sustainable for us to be in an ACO type model is attribution. And under MSSP right now, attribution is done just at the TIN level, the full TIN. And so that results in a pretty meaningful amount of our attributed patients not actually being our primary care patients in the traditional way that I think most of us think about primary care. Our academic medical center TIN, for example, we see that over 12% of the attributed patients within that TIN are attributed via a visit with a specialty APP, mostly oncology and cancer. So we would like to see an attribution model that's based on TIN and NPI attribution, and we think that would help us actually get a patient population that is closer to our more kind of, again, the classic quote unquote primary care population, as I think a lot of us think of it.
Yeah, great point. Next, let's hear from Michael.
Sure. I'd echo both the comments that Jessica and Chase mentioned, and just add a couple things. I think from a health system standpoint, one of the things that we really have to balance is the multiple revenue streams, and so one of the things that we try to do, specific to Medicare models, we try to tie in, what's our margin on our Medicare business as a whole. How are those sites performing in the Medicare value-based purchasing program? And then how would reduction in admissions and readmissions and subsequent services impact their bottom line? And what we found is when we can speak that language across our different organizations, we can typically get the health system on board. But because we also have the independent physician groups, where they've struggled, particularly on the cash flow side, is for ACO REACH, for instance. We approached about 35 of our practices to participate in ACO REACH, and they had to give up their guaranteed fee for service revenue to take on capitation in a global form from us. And while we could lay out our predicted increase in their revenue from participating in the model and their predicted increase in their shared savings check, they were hesitant to do it, and ultimately only signed up about 30% of those practices because of the cash flow implications and the challenges around waiting for some of those dollars. And then in addition to that, I think for us, it's really key to understand organizational readiness in our different markets. In some cases, smaller, independent physician groups in more rural communities do actually are a little bit more nimble and flexible with the infrastructure that we can provide it from a health system standpoint. And so we do see them, take on a little bit more risk in some areas, and being a little bit more nimble and sort of first adopters in some of these spaces. But again, some of that's enabled by, the health system support. And I think without that might be even more challenging for some groups.
Right. Thank you for that. Brock and Christopher, other comments?
Yeah, thank you. This is an important question, and I think for our rural hospitals and clinics. I think this is central. Obviously, I said in my intro that in those roughly half of hospitals that are not affiliated with a system, like Mike mentioned a second ago, they are independent, and meaning that they have leadership in their organizations that are often a mile wide and an inch deep. And so when you talk about complicated in programming, such as population-based total cost of care, the level of complexity becomes overwhelming. And then you have just an inertia that occurs in terms of being able to carry off a program or a participation in something like this. One of the ideas that I think we're seeing nationwide that is starting to take root is development of networks around the implementation of these kinds of programs through a clinically integrated network that's loosely affiliated between independent hospitals in rural areas. And this is something that is being experimented with, and I think would be the foundation, if you will, for then moving into some of the more complex models that we're talking about here. I think that many rural facilities don't understand, and again, have a difficulty assessing the risk. And so that comes back to the discussion in terms of their financial wherewithal to be able to, I mean, many of them are worried about keeping their doors open, making the next payroll, and making sure that they can stay open into the long term. And so when you're in that kind of operational mode, it's difficult to think long term about these kinds of programs. And so I think organizationally, this is something that we struggle with at our association when we evaluate programs that would be applicable for participation by rural providers. It's the complexity. And I think that often we get frustrated because these larger, more sophisticated models are not well suited to the rural environment. And so we keep talking about a rural relevant or a rural centric model that does have an opportunity to take into account low volumes, which are really the factor that creates complication for risk in these rural communities.
Yeah, I'll just add one to kind of piggyback on that. Catalyst has been URAC accredited for a CIN for 7-8 years, since 2016 or so, one of the 6 or 7 in the country. What we had to do, and we have a combination of, while we're in North Texas, which is evolving to the biggest metro area in the nation, I also have not only the Panhandle but communities in East Texas that range from 10,000 people to 30,000 people. And again, I grew up in a town of 7,000. So how we talk about this from a rural setting, to your point, is completely different to me than how we talk about it in an urban setting. There's just a different solution set that we have to think of it there, because the rural communities, going back to my point about thriving communities, you have to have the education and the healthcare and the jobs. Well, those smaller communities often struggle in all 3 of those, and healthcare being one of the biggest ones right now. If I take it back to the urban setting, though, and say a little bit more about, Chase kind of alluded to it, I think everything starts with incentives and alignment. So the ownership structure and governance kind of is your starting point. And what does a hospital system, Mike talked about the dynamic tension between that. Well, I talked to all the hospital CEOs about that around my areas. It's hard. You're going to rob Peter to pay Paul. They're 2 different 180-degree different models. If you're in PE, you're in and out. It's not going to be something long-term, and these value-based systems usually need a longer tail. So right there, you kind of have different issues just as your start. Before you even get into, does the financial model even work? Then you get to that. And, Jessica spoke to the difficulties in that, and certainly the incentives and the timing of the payment, the investment. Do you even have the capabilities? And if you get to where it makes sense, do you have the capabilities? How do you invest in that? And then if you can conquer all 3 of those, then you get into what I think it was Mike was talking about, is like, how do you even get physicians to think about change management in a world where the majority of their pay is still in the from a primary care setting, I'm going to take off I don't have the specialty hat on here. From a primary care setting, the Stockholm syndrome of fee for service, where they think that that's the only way that they can work. And I have a very similar situation I did to my CAD, is where I can actually show people that their prospective capitated, I don't use the word capitated, their subscription payments are better than their fee for service. I can show them the math and they will still say, I'd rather keep my fee for service. It's very, very, very interesting. Even though they want change, they have a hard time changing. So, there's a lot of hurdles there to get over. And we hadn't even talked about data yet, but that's a whole nother category.
If I could add one more thing that I like the Stockholm syndrome reference, Dr. Crow, but I think one of the biggest factors in all of healthcare is the payers, right? Especially as they relate to small physician groups or even large physician groups, right? They absolutely drive decisions around when to participate and how to participate in these models. The commercial payers and their semi-legal monopolies, right, drive physician groups into larger risk-based arrangements that maybe they wouldn't have otherwise been in. And so I think it's hard to talk about what's impacting groups' decisions without talking about how the payers are acting.
Great points, Christopher. I especially like your point. Change is great as long as someone else goes first and shows how it points the way, right? Wonderful discussion. Let's raise it to the committee. What questions do you have on this question of most important factors influencing different types of decisions? Jake.
Thanks, Lee. This is for Brock and anybody else who wants to comment. And this is going to be a sacrilegious question because I think we need to take into consideration for some rural hospitals, just population-based total cost of care models just don't work. That we need to think, differently, and whether it's, quality-based bonus structure built around fee-for-service, because one size doesn't fit all. I like the clinical integrated network design, but I think we got to think this through because these hospitals, we're talking about survival. They're not thinking about a capitated payment because their volumes are small. And the irony is most of these hospitals, when they get in a growth mode, they all want to add beds and they all want to add service lines. So we've got this dichotomy operating all the time. And I truly don't know how we break it because I've watched it happen in certain markets that we happen to be in. That they all want to grow, add beds and add service lines, which almost gets contrary to a population-based, value-based purchasing model. So, how do we balance that to keep them solvent and ease them into the transition?
Well, that's a great question. And if I had the answer to that, that was easy, I think I probably wouldn't be here talking to you. I would be probably on a beach someplace enjoying my wealth. I think I look to models that we've used in the past that have been successful. Unfortunately, they haven't passed the muster of CMMI's definition of a beneficial program. But the Pennsylvania rural health model, which is the global budget, was a model that started in roughly 2017, 2018, and sadly ended December 31st of last year. And the global budget basically sets forth payment to the hospitals on an average net revenue for the last 3 years. But the important piece to the model that employed was the Rural Transformation Plan, which was the requirement that they would enter into a discussion on how they would do exactly the opposite of what you said, Jay, and that is we're not interested in building more structures. Obviously, bricks and mortar are no longer where the action is in terms of healthcare. And we need to start looking at how we reformat our services so that we move into access, care navigation, chronic care management, and the things that rural facilities can excel at and do very well in. But one of the things that we have discussed at infinitum in our work is that we have to preserve what we have before we can move to something different. So we have to make sure that we don't close 30, 40, 50, 100 rural hospitals while we're figuring out this new model and have these casualties along the way. So I think this rural Pennsylvania model, this global budget model, was one that showed a lot of promise. And that goes back to the churn notion that I said a second ago. Now that program is ended, out of 18 hospitals in Pennsylvania that participated, I think 15 or 16 are continuing in spite of the fact that the program officially ended. So, and that's for the Medicare only piece of the program. So I think it shows that it was demonstrated to work. It just didn't meet the criteria that CMI was using in terms of providing savings to the overall system and being able to demonstrate that as part of the requirement.
Yeah, I might add to that. I would double click on and bold your global budget. I mean, living in these communities growing up and working in them now, and it starts with what I said earlier. It's really about the ownership structure and who accrues the benefits of the care in the town. And that really is, a pillar of the thriving community. If we have rural hospitals that are all incentivized to be owned by somebody in Nashville, it's just not going to work, right? These are literally, we call them hospitals, but I like they're more like community centers.
Mm-hmm.
It needs to be where the physicians, the primary care physicians, the nurse practitioners, the nurses, and those other acumens, like you said, they're doing care delivery. The people in those towns are highly engaged with each other. You need to leverage that. Leverage the power of the engagement in the community. And again, I agree with you. This service line that you talk about and trying to add things is all about trying to pull people out of that town to go get more expensive care somewhere else. So you almost have to think about these like if you had to start over, what would you create in a town? You would create a community center of health that has a few beds in it for sure. And has a global budget. I don't have the answer how to do that. I'm just telling you, it's way, way different. And I watch these little towns in Texas die on the vine right now because of their hospital it's either their hospital or their school district is hemorrhaging, or both.
Yeah.
We're going to go Larry, Jim, and then Lauren.
Great discussion. I have so many questions, but for the sake of time and not wanting to dominate, I'm going to start with one for all of you. Some common themes have come out from all five of you, that the time between performance and payment has to be reduced. We need to have a feasible path to generate savings. There has to be the right balance in risk and reward. My question is, what level of reward over risk would move your needle? How big of a benefit has to be there? Is there a hurdle rate? And can you state some successes? We heard a lot of barriers, but can any of you elucidate success stories? Like Michael, do you have a nesting success story? So I know that's a couple of questions built into one, but I really want to know, is there a hurdle rate when you're making these decisions? And give me a success story.
Yeah, I can start. So first, your comment on the hurdle rate, at least particularly for us, I think, I'm just looking at some stats here. MedPAC found, I think, average margin for hospitals in 2022 was, for Medicare patients was negative 12%. Obviously, that's variable across a variety of markets, but at the end of the day, payments for Medicare services on the inpatient side in particular are not going up; they're going down, right? And so the hurdle for value-based care within Medicare, particularly on an ACO side, is coming down. And I think where we've been successful in pushing this, I mentioned, our ACO or Medicare is our biggest payer in the value-based care space. I think the incentives are there where I think large integrated delivery networks struggle is really managing utilization and the complexity of that. And that's where I think you see a lot of success in the physician-led side. In terms of an example of a nested model, we have several aligned nephrology groups within our geographic regions. In particular, one larger group in Wisconsin. They had previously participated in MSSP, sort of felt a little bit disconnected, did evaluate the CKCC model, and opted instead to participate in the Medicare Shared Savings Program. They're a participant of us. Based on other models and other demonstration projects, we created a 3-year baseline for their patient panel. They got about 3,000 members, and we carved out their population, from our MSSP, created a baseline, trended those costs forward with our actuarial team, and looked at their performance over time. Couple stats: that model's was live in 24 and continues in 25. From our perspective, with the practice, we committed a certain amount of shared resources to do care management, outreach, et cetera. Results have been 25% increase in transplant for kidney care patients. We've seen an increase in efficiency and productivity at the practice, just simply by shared problem solving, both with technology and working together with the group, with our quality improvement coordinators. And we've seen about a 10% decrease in readmissions across the board. We're providing some services like transportation and other things through the waivers allowed in the program. And it's really solved an access issue. It solved some productivity issues. And it's simply just working together with that practice to focus on their CKD stage 3 through 5 and end stage patients. I think there's other areas where maybe we haven't done as well. You look at sort of complex, long-term care patients, right? We maybe have responsibility for them, but we may not be the best group to manage them. And so we've evaluated, you've seen a couple, long-term care ACOs, you've seen highly complex ACO REACH entities sort of come aboard. I think there's an avenue to partner with those folks. You can see some really significant results for folks that maybe are managing care outside of the 4 walls of our hospital or the ambulatory settings that we're in. Those are a couple examples. One last example, we believe in episodes of care, and we are building our own infrastructure and technology. This would be a plug for the group. We think standard episode definitions such as PACEs would really alleviate the burden on organizations to select one of the 160 groupers that are out there for a variety of episodes of care. I think roughly about 75% of care can be grouped into an episode. 75% of Medicare claims can be grouped into an episode. And we believe that's the future. And so we've invested a lot of time and effort into building that infrastructure capability within our organization.
I can jump in with some thoughts, and I'll try and be succinct because I know we have a lot to get through. In terms of your question of the hurdle rate, I'm going to be a little annoying and kind of not answer it and say that, these things are not decided in a vacuum. And I think that the greater uncertainty that exists within the health system, the less likely you are to be open to taking on risk. So, if you're concerned about like if telehealth might go away, what's happening with physician payment, those are things that make your overall appetite for taking risk less. And so sometimes the question becomes, within a given model, how much is risk limited versus like what the gain is. And then an example of where we had a win, I would say, when you start with a model that's kind of answering a key question, like what is this model trying to solve to, versus just kind of having the model for sake of a model that might involve certain specialists, is where we see a kind of path to success. And so I'd say for joint replacement bundles, I think those came out of 10 years ago now, research showing that there's a ton of variation in post-acute care spending. And so with that model, we looked at, really scrutinize what criteria do we use to recommend where a patient goes post-discharge. And we were able to kind of more standardize our process for what type of patients like most need to go to a SNF versus an IRF versus home with home health. And so I think we are able to improve the patient experience, but also generate some savings within that model.
And I'll add one more answer to this. As the primary care guy that had, we have several hundred physicians inside of a risk-bearing entity doing full risk on about 80,000 Medicare and Medicare Advantage lives. You asked about a hurdle rate. I can tell you by experience, I had to throw a lot of things against the wall to try to figure out what the physicians could get to understand how to do a prospective payment and teach them to get out of their own Stockholm syndrome, as I called it earlier. And I had to have a prepay some what I think would be performance, surplus, gain share, what you want to call it, into the realm of around 140, 50% of Medicare from their traditional Medicare rates to get them to have their eyes open up enough to go, wait a minute, maybe that math does work. And that's one answer to your question. Here's maybe a more or an as important one is what percentage of their population that they serve can you actually get into that model, where ultimately now the financing model then drives a different clinical model. And we have just kind of crossed that line to where I would say, 40-ish, 50% of our physicians are now being paid in a prospective payment model with surplus, and it's beginning to change their mindset. So our clinical model, for example, now spends a ton of time asking the question, so this goes to the success story, how do we think about end-of-life care, where most of the expenses are? It is the last thing you think about in fee-for-service. I practiced for 12 years, never thought about palliative, hospice, and that's embarrassing to say, but it's the truth. Because the fee-for-service model does nothing but disincentivize you to spend time on those conversations. Now it's the exact opposite, and we're looking at who are our highest risk patients, how can we intervene on them earlier, how do we think about heart failure? Like, it's a different clinical model, and I will tell you, the physicians love it now. I got physicians who say, I want to practice longer because I feel engaged and I'm less burned out. That burnout word has been around forever, and I'm trying to get rid of it. And this is actually our path to freedom, is what I tell them, is when you get on a subscription model. But you can't do it at 5 or 10%. You got to push all the way, which goes back to Chase's point that I didn't make, that I'm glad he did, is unless you have a multi-payer alignment of these models to some extent, it's going to be really, really hard to get to that. It took me years to get to where we are today.
One of the things I'll just quickly mention, it's not necessarily a hurdle, but in the Pennsylvania rural health model, which featured the global budget, that was a multi-payer program. So it was Medicare, state Medicaid, and then also three large insurance companies, commercial insurance companies participated. And I think that was a huge benefit to the facilities to align all of their incentives, both financially and in terms of quality reporting, so that they're all aligned along the same pathway in terms of incentives. And it kind of goes to my motto, is that incentives matter, and how providers are incentivized to provide care is exactly how it will be provided. I know as a hospital administrator, going back into the good old days, I call them now, I knew how to titrate a response to my financial situation by exactly what was mentioned earlier by Jay, and that's increasing service lines, making more profitable services available to members of my community. But that's no longer what our communities need. And I think that this incentive to provide those differences through models like the global budget really provide, I think, the necessary inputs to be able to help make that happen.
Yeah, I think for me, Larry, when you ask what some CFOs what the hurdle rate is, it's going to be it's a dangerous question. But Dr. Crow throwing out the first number. I think Dr. Crow's right. The model has to match the incentive, but on this call we're talking a lot about what are the barriers, and for our physicians, the barriers are the bigger issue as opposed to the risk versus reward. I mean, I'm sure there's a teeter point there somewhere, but it's the data, the cash flow, right? The trust in the data, and I think Mike made a great point. You know, when there's 5 to 7 different, you know, VBC plans, each one's looking at, you know, something different, right? And so now you got to manage several different plans. It's the burden's just significant. So I would say just for us, it's less about the hurdle, whether it's 150 to 200. It's more about how do we remove the barriers, because again, to Dr. Crow's point, the model's there. We just have to figure out how to operationalize it.
Thank you.
We'll go Jim and then Lauren and then Henish.
Thank you. Thank you all for taking the time to talk with us. I want to kind of take us back a moment and say part of our conversation over the next couple of days is to think through, number one, the barriers that y'all are articulating, but also maybe new pathways that could be created that address some of the key barriers that you're identifying that would incentivize increased participation. And I was struck by the particular area of interest Chris brings up as being someone who came from a small town. I'm someone who practiced in a small town in Texas. And the rural health critical access hospital intersection around our core infrastructure for a significant portion of the population in the United States, as a way to illustrate the idea of pathways that could attract large systems or large successful organizations like those represented on the call in this discussion here. So you mentioned kind of the multi-payer strategy that has had some effect and might actually be able to entice, if you will, successful organizations like yourselves to move toward collaboration with critical access hospitals that are struggling. And Chris, I maybe want to have you start with this because I know you, is this idea of if it actually collapses like we think it might, or it already has in parts of Texas, or Lee's from Oklahoma, how would you go in and say, well, what type of incentives in a pathway related to an APM that you're participating in would want you or encourage you in a Northwestern and Dooley, an Advocate, same question, to move toward taking your skill set, your energy, your passion, your knowledge, your experience, and really lifting up in some type of partnership? What would you need in that pathway to reduce the barriers that you already know that are out there? Because the thing is either on the verge of collapsing or is already collapsed, and now we have to go rebuild it. So I'm gonna kind of, and I think you got me started thinking about this multi-payer alignment as kind of like a key solution set. But I thought maybe I'd open that up, the whole question up, and see what your opinions might be.
So I think you asked me to go first. First, I like the beard, Jim. I hadn't seen that. Good ad. Secondly, I guess I think your question was, what would attract someone like any of us to go into a rural community that's struggling? Like, what would be some of the characteristics that would have to be present to go in there and help? I think was the question. Am I right? Similar? Am I about right?
Yeah, you're on it. As an illustration of these pathways we would like to talk about. Yeah.
The one thing, like, and we've mentioned it multiple times already, is like the rural communities have a higher density of Medicare and Medicaid. That actually simplifies potentially what you could do. The other thing that I said was they're very engaged. So I actually have very good conversations with, school districts and cities and counties, which are generally the largest employers in those smaller communities. So you could actually get some type of alignment through if you had one government kind of connection plus a little bit inside the big three in the town. You can almost create a single budget. Now, the other thing you said, like, what else would you need? I would need time. You can't, this can't be a year to year. This has to be a multi-year, call it 5-year investment of what it would take to figure out each community's needs, because they're different, they can be different, and what capabilities you would need to bring in terms of acumen. So there's an alignment of a singular, multi-payer but singular model. It'd have to be, to me, a global budget, and you'd have to have some time, and then you'd have to agree upon, what are the 2 or 3 main metrics we're trying to do to help save that community. And the first thing that comes to my mind is whoever owns that hospital may or may not have the same alignment to what you're ultimately trying to do, and how would you conquer that? So those are just my first thoughts. It's something, like you said, Jim, you and I are both passionate about, and I find it incredibly difficult to think about how we could do that. That's my first thoughts. I'm sure these other people will have better ones.
Yeah, I would just comment. I think Dr. Crow said it very well. I think there's some elements of this in the AHEAD model, right? Which is just getting ready to kick off. I think there's some elements of it in the GEO model that came out of CMMI that was ultimately canceled and is maybe gaining steam again. I think it's a combination of probably both of those, plus some acknowledgement or some focus around the communities that are struggling, and some sort of benefit or support for them that's a little bit more direct, so that organizations that are serving this larger geographic area are focused on what the intent of the model is, particularly for these rural communities.
Okay, next is Lauren.
Really appreciating all of your comments. I spend a lot of time in rural environments helping people stand up systems of care for complex populations, but also have been involved in implementation of ACOs and multi-state health systems in urban areas. There's a couple of areas I'd love to hear you comment on. They lean more towards rural areas, but I think they apply as well in urban. So I'm curious what policy flexibilities you think are essential around core components like telehealth, mobile health care, virtual care management, and innovations in payment for transportation for success in population-based total cost of care models. Maybe start with, I can't see right now, the National Rural Health Association, and also Chris, and then go around the room.
Well, thank you. That's Brock here. Yeah, I think you raise a very, very good point. I mean, I think that these new modalities around connected care are really critical pieces to fit into this puzzle. I think a lot of our members, a lot of our providers around the country are frustrated with the fee-for-service arrangement around at least telehealth at the moment. Frustrated that the payment isn't on par with their requisite provider type. So if you're a federal qualified health center, the reimbursement for the telehealth service is less than what you would get under PPS, and same with the rural health clinic. I think that where we would come in on this is that we want to get parity on those services, so that, again, preserving what we have now so that we don't endanger it going forward. But I think that as a now putting on my hat as a provider and simplicity, I think that these connected care modalities are going to have to be incorporated into a value-based care model, so that this fee-for-service arrangement isn't going to incentivize, once again, behavior that may not be exactly what we want in this new paradigm. So So we're at this crossroads now where we're kind of inching into, and now, of course, artificial intelligence is a whole other conversation that's going into the space here. And I think that that's a critical feature. So we need to get parity with the payment, at least in the rural provider context, as we start to incorporate those more completely into the value-based care paradigm, so that we're not creating another monster that we someday have to have a whole conversation like this group is having on how to fix it.
Okay, I think you named me next in line. So here's how I think about this. These, telehealth, God, I go back to even CCM that I helped design years ago. Good ideas to kind of move us in, but when it's in a fee-for-service world, all of a sudden there's telehealth companies, all of a sudden there's CCM companies. You give a code and you create a company, RPM now. So again, from the primary care physician standpoint, who I believe has a longitudinal relationship with their patients, and that is actually where the ROI happens. The relationships compound the same way interest compounds. You make tiny decisions year after year that add up to big decisions on people's health, and you do that across a population, and that helps their overall health. So I go back to, I don't use the word capitation. I go back to, we really need to be able to have subscription models. How would you do that? You could do it at the government level, like I already have with all my Medicare and Medicare Advantage. From a commercial standpoint, if we could unbundle, primary care shouldn't be your insurance. Insurance is when bad stuff happens. Primary care is stuff that happens all the time. So how do you unbundle that and make primary care something that's tax deductible for the individual, the same way it is for the employer? And whether it's their deductible, their FSA or their HSA or whatever it is of the benefit design of the day, encourages the patient to actually have a longitudinal relationship with their PCP in a tax deductible format. And therefore, you don't start counting ticks and ties of, do they have this RPM? How many times did they use it? And what is this telehealth code? And oh my gosh, I can only get paid if they're in my 10 by 10 exam room with the crinkly paper and the old magazines. It's only, like, it opens up a delivery model, like, what do you need to do to take care of them? And the center of healthcare moves from that little office into wherever the patient is. And you build your delivery around that, which is what I've been able to do at Medicare and be successful with in the last few years, because we got the delivery model that we wanted, and it's a lagging indicator of a financial model that allows us to actually do that. So that would be what I'd say we need.
I think there's an aspect of kind of this telehealth delivery that we haven't really talked about, and it's at least in rural communities. So Springfield is a couple hours south of Chicago. So we deal with it less at Dooley than we did at Springfield, but Quincy, which is part of Dooley as well, like shortages in clinical care providers, right? So both physicians absolutely in those communities, but also MAs and nurses. Right, so the ability to get paid for telehealth services, right, to allow our MAs and our nurses to connect with patients when they're at home or in other areas, it's going to be critical moving forward for these smaller communities to be able to connect with their patients. Which to Dr. Crow's point, and this is something we talk about at Dooley all the time, that doctor-patient relationship is sacred. And we have to preserve it. It's not something that I don't mean to speak pejoratively of like Amazon care or whatever, but a patient in rural Springfield isn't gonna want to have a relationship with a doctor, 1,000 miles away. Like that relationship is sacred. So telehealth's important, but it's important within a community.
Great comments. And the longitudinal component too. We've consistently heard that, how important that is. Would anyone else like to comment? And I'll hand it over to you.
All right, pitch to Henish, and then we'll move on to the next question.
So this is a question for all five of you. We've talked through quite a few meaningful barriers and participation for each one of your organizations. But I'm curious, just taking a look at that 2x2 grid of high value, low value, high lift, low lift, what are some And each one of you represent a different sector, different type of organization. So what is that higher value, lower lift, more immediate change that can be made in these models to help move your organization more towards population-based total cost of care and improved patient outcomes, et cetera? I mean, for example, Jessica, you gave the example of the TIN NPI, right? That's a very specific change that can be made to help progress that. What would that sort of an example be, one or two for each one of you?
While people think about that, I'll just add on that's something else that I think is easy for CMS to offer is a longer implementation timeframe for models. So I know for us, when a new model comes out, I'll take the guide model, for example. We did a kind of quick assessment of it to see where are our gaps to being able to satisfy all the requirements and, what's the ROI, the lift to fill those gaps in the timeline. And we were basically like, oh, we have so many competing priorities right now. Like, it's like we aren't going to be able to devote the resources to that right now. And I think like a good example, I know that a lot of people have issues with the team model itself, but the fact that unlike past bundled payment models, CMS gave over a year lead time for that model, like that kind of lead time is very helpful. And I think a pretty easy thing to grant. No, so not commenting on the team model itself, just the lead time for it.
So both the lead and the duration?
Not the duration of the model, the lead time up to it. So when you know about it, when you actually like press go and payments start changing, you have to start reporting data and all of that.
This is Brock here, and thanks for the question, Hanish. I think that the high value would be, and I would go to the word simplicity, a model that is simple in terms of understanding and its creation and design. That usually tends to be more elegant. I hate to come back to the global budget, which is a part of the AHEAD model. And to Jessica's point, they did do a 10-year horizon on that model. So they've learned, I think, in terms of the duration of the model to make sure that the reporting period upon which success or non-success will be determined has a longer running period to be able to make that judgment. One of the things that I think that could be done and is being and is important in this sense is providing technical assistance for the implementation of these programs would be incredibly powerful to be able to have a lead time in application for consultants, which unfortunately would usually fall to them, to help and guide facilities in their applications to these programs, because I think these are very difficult applications to fill out and to complete and think through the entire model. So I think technical assistance could be very helpful to a rural independent facility looking at some of these models.
So Brock, before
Yeah.
you go on, maybe just to clarify a couple of
Sure.
things. Are you implying that technical assistance from CMS to the people who are looking to participate in the models, or just enough lead time so that the participants can engage with another entity to help figure out whether or not they should participate in the model?
I think both, frankly, but I think when I say technical assistance, I'm not necessarily meaning from CMS, but allowing for the engagement and perhaps providing resources to the facility to engage consulting to help them with this. Because again, we're going back to this model where one of the barriers is the facilities are not well resourced, both in terms of leadership and in dollars. And so they don't have an outside or a department for strategic analysis or all of the things that we're talking about here. So it all has to be accomplished with the existing infrastructure of these facilities. And often there's a will, but there may not be the means. And I think that's what I'm referring to here in terms of the application process. But once you get into the program, I think it's really important. And then like in the AHEAD model, it depends upon state participation. So even if you're an individual facility that wants to participate, there has to be a regional or a state program entity that organizes the grant application to CMS. So that makes it really out of reach for many, and just using that as an example. And I use that for the 10-year horizon on the demonstration, which I think is really a good period of time to evaluate its effectiveness.
Is there a model that you found, Brock, that is pretty, I guess, simple? I mean, not as simple as you would want it to be, but it's getting closer to the type of model you would want to be, and maybe a couple of tweaks that would get it to a place which would substantially increase adoption.
Did you say the AHEAD model, Hanish?
No, just any model, I mean, that you found. Yeah.
Oh, yeah. I think that, well, the AHEAD model is actually a pretty good one, because the problem with it was it wasn't exclusive to rural. And so I think there was some concern from some states about a mixed participation between facilities in different, urban, suburban, and rural. And I think there was some hesitation there, if I'm remembering that correctly. But I think that incorporated a global budget, a physician compensation piece, and then a total cost of care wraparound. So it had three elements that I think would be important for a rural community to be able to evaluate. But again, I go back to the technical assistance that's needed for, if it's a rural facility participating, being able to understand the impact and assess its value.
Yeah, I'll go. I actually have a hard time with this question, Hinesh, because little effort for one might be high effort for another. I mean, and I think, what Roger said, like, it's a high effort for a group to be able to create the capabilities. Or if we say, hey, we want the government to provide the technical consistency, and so it's a little effort on the community to do that because it's going to be given to them, then it's high effort on the government, right? So that whose effort is something that I'm playing with in my head. But
just to clarify, Dr. Crow, for your specific type of structure, model, etc., what would be the lower lift, higher value thing that can improve the work that you're looking to do to progress into total cost of care?
I don't have let me just say this, and then I'll shut up, because I don't have a great answer for you in this one. But I do have an analog that I think about. If we as a government really think that this value-based care thing is important, and then we got to go all in, maybe differently. And I'll go back to like 2004 when we decided that everyone was going to have an EMR. Think about that. In 2004, people were fighting it. I don't want it. Only 15% of the country had it. We decided to create, David Brailer comes on, we create OnChit, we create the regional extension centers. We go full board. In 4 years, we get to 80%. So I almost say that like this, y'all were talking, and Jessica talked about, hey, I need to go, it needs to be slow, and we need these 10 years. And I'm like, I sit there, I tell myself, yeah, I agree with that. And then I say, you know what? Until we like really decide and go all in, then it'll always be this little iterative stuff. We're here in 2025 talking about value-based care, and I started in value-based care in 2006. And so until we like really say we're all in and create the national infrastructure to do that, that would be what would become simple for all of us to say, all right, well, I guess we're going to do it. And all of a sudden we have EMRs, and we can all talk about whether that was good or bad. But I think we all can agree that it's better than the paper charts that are taking up, closets. Sorry for that.
No, I agree with that. I mean, my comment was going to be sort of right on the quality measures within the Medicare program. You've got ECQMs that are, all payer or multi-payer. Multi-payer database and or model with specialty and primary care models that can expand across payers, I think we'll move the dial. There are even ourselves, we have so much infrastructure tied up in trying to meet the demands of individual contracts for different primary care mechanisms and different quality measures and different things, that if we could rechannel that infrastructure into a singular model where every patient gets, deserves to get the same science, and the way to deliver that science may differ by locale, in that last mile, then I think we're actually going to move the dial. Now, I realize that that's a heavy lift, but it could start with some incremental changes like a multi-payer database, some multi-payer methodologies that expand across the board. Maybe, one small foray into that is sort of shadow bundle reports that are going to ACOs, but that's not enough, right? Like, that's a small foray that people who, are sophisticated and can have the time to do that work and build a model around it can do it. But it needs to go a step further. Methodologies, risk adjustments, all that sort of stuff could be standard across payers, and then we could really stop wasting time meeting some of those demands and start focusing on the patients and the improvement efforts.
Sure. I mean, something simple. I think that could help. Some of our groups is aligning, attribution, risk, is in models like ours. That first year patient is significantly more expensive, significantly more a draw on profitability. And so, if we're thinking simple solutions that would allow groups to consider joining, right? It's that first year cohort. Can we do something with the risk for that group? And then because as they move through care management, a good care management process, right? That profitability gets there. Year one's a draw. It's something simple as reducing the risk on that first year cohort would be a potential solution.
Thank you so much.
All right, Walter.
Thank you, Lee. Great discussion. Thank you, everyone, for sharing their expertise. My question, I'm going to take it down a level a bit and talk about what I refer to as the last mile problem in value-based care. And that is kind of what Chris referred to in terms of having enough financial incentives to change clinical behavior, right? So let's just say you have a value-based organization that has a great care model, you're achieving shared savings. My question is to the different organizations represented around the table here, how do you get those shared savings to the frontline clinician to sustain their continued change in behavior? I think probably a lot of the answer might lie in what Chris discussed around the importance of ownership and governance. But I talked to a lot of physicians who say, I'm doing what you asked, but I'm not seeing any of the benefits. And so, I'd love to hear kind of some a bit more tactical suggestions or recommendations around what best of class organizations are doing to sustain the change in clinical practice patterns under value-based care.
Start. And there's lots of different shared savings distribution methodologies. And so I'm sure there's, other panelists could probably speak to those in great detail. So you can go that route and of course tie distribution of savings, different quality measures. You can even look at individual physician level benchmarks that are risk adjusted if you like. But at Northwestern, where the majority of our physicians are employed, we do have financial incentives tied to specific measures, but one thing we're increasingly looking at is pointing out what we've already invested in that they feel every day. So like an AI scribe, for example, different things that hopefully enable them to practice at top of license and remove some of those kind of daily, like pebble in the shoe type things, to looking forward to the kind of bigger scale investments that we would like to make, that would make both their days easier, but also really help their patients. So social workers, pharmacists dedicated to clinics, things like that, that are frankly a win-win for everyone, good for the patients, good for the physicians, and also would contribute to the success of our BBC contracts. So aside from the kind of classic shared savings distribution models, we're looking at those infrastructure investments that hopefully enable our clinicians to just better practice at top of license. And I think we more give them direct dollars for some of the things that are like the extra clicks, so to speak, that really do not feel like top of license, but we can at least tell you like, hey, we recognize this is extra work on your part, so we are recognizing that financially.
I think to one of Brock's earlier points, as models change, how we compensate the physicians change, right? How the models iterate every couple of years, right? Really throws a wrench and how compensation to physicians work and really how we incentivize their activity. One of the things that we're contemplating at Dooley is how do we there's such a dichotomy, right, between the VBC business and the fee-for-service business and how we operate it. How do we bridge that, right? How do we look at, to some of Dr. Crow's points, right? The work that we're doing for VBC patients really would benefit our commercial patients as well. And so can we create standard models that works right across there, right? We bring in our sickest, 5%, 10% of VBC patients 5 to 12 times a year. What if we had an approach where we looked at our commercial patients that way and had a series of services that we provided to them? Maybe it's on a subscription model. As we think about the clinical care model and operationally through a clinic, right, treating every patient more similarly, I think really helps the physician practice. Again, back to payers.
I'll give you kind of our perspective and give you a specific. So like 70% of every dollars that come in go to the physicians. That's a way. It's been that way with us for over a decade, and that's just the way we operate. Secondly, I would say, Jessica didn't say it this way, but and by the way, I'm a family physician by training, and I hadn't seen a patient in over a decade, so I'm really useless in that way. But I still do carry that history, which allows me to say things about my fellow physicians that some people don't want to say if they're in an administrator role. But it's constantly of what have you done for me lately, right? And you have to remind them, to your point, Jessica said, like of the things you're doing for them, quantitatively and qualitatively, because they care about 3 things in differing order depending on who they are and time in their career. But they care about their time, they care about their money, and they care about their ego. Okay, and so even family physicians have ego, not as much as orthopedics, but it's there. So how do you address that? Knowing that, how do you address that on a regular basis? And so we have a very consistent, intentional educational process that we use and are always iterating on to be close to that physician, to make sure we're educating them. Again, I'm at a different stage now because I've now gotten to where they're ready to change the clinical model because they understand the clinical model drives the financial model for them. 7 years ago, none of my doctors wanted to take Medicare. Now they're asking me, can I stop taking commercial for all the reasons you guys have been saying, that it's too hard to manage all these things. And now the commercial payers hadn't paid me anymore in the last 5 years. Right. And so it's a very different mentality, but it comes with consistent education around that. And then the second one is there's still the cash flow issue. So as we've been able to perform, we've been able to get contracting in ways that brings more dollars into the forefront, so we can begin to connect the clinical activities to the financial. And what used to be 18 months, I got it down to 6 to 9. And then if I can bridge the gap a couple more months, it's not as, physicians still have a hard time in reporting, just even though they're paid 30 days later in fee for service. When I give them their reports, they're like, I'm busy right now. Why is this not more? I'm like, because you were on spring break 6 weeks ago. So it's hard for physicians to be able to match times and dollars, and you have to constantly be able to tie those together. And what we do now is we show them, here are the activities in value-based care that are the most important. It's senior high-risk patients. It's, hey, how are we doing on medication management of our chronic disease? Hey, what are we doing on end-of-life care? What about our patients that have, end-stage renal disease? What are we doing? I mean, it's getting kind of into the right this dialogue around their population rather than them going around the wheel of their exam rooms every 3 exam rooms. And that takes time, especially when you're someone like us, or one of the few that are really pushing the envelope, because the national strategy has not gotten to what I asked for earlier, which is let's go all in on this. And so we're constantly swimming upstream, trying to slowly but surely just take little nicks out of it year by year and survive in advance.
And I'll just quickly add, this is Brock here, that I don't think it's just the physician, it's also the advanced practice providers, the care teams. All of the way in which we're organizing care now is towards a team-based care, going to your last mile analogy. And I think that we need to be adding value to the teams that are assigned around each primary care physician. And then having those rewards, I guess, distributed to everyone within the team for the care of the patients that they're having their panel. And I think it may be in this environment moving ahead, it's not really so much about encounters on a daily basis, but your panel size and how you manage a group of patients versus just them individually in an encounter. And that's a whole nother way of thinking going forward.
Okay. Thank you so much for those hard-won lessons and pearls for the committee and such rich conversation. It is now 12:10. I'd like to thank all of you for joining us this morning. We really appreciate and respect your valuable time and wisdom. You've helped us cover a lot of ground this morning. I've got pages and pages of pearls, and I'm sure my fellow committee members do too. You're certainly welcome to stay the rest of the day and listen to as much as you would like to. But at this time, we're going to have a lunch break until 1:10 Eastern Time. Please join us back at 1:10. We have a great set of experts for our first listening session, which focus on reducing organization level barriers affecting participation. Thank you so much. Appreciate your investment today. We are adjourned until 1:10.
Produced by the U.S. Department of Health and Human Services.